Okay, so this is Linda and me, and we're going to do the prescribing update. So we hope we've got some pretty neat things for you. Neither of us have got any conflicts of interest in the last 5 years, so that's a good start. So I'm going to talk about the sprint trial. Those of you who have Matt Dawes the other day would have heard about this. I heard about it in September last year. Oop. Not moving, John? This actually hit the headline. Some of you would have seen it on Medscape. It came out about September and says that 120 is better than 140, but there were no numbers. And I searched and I watched the web and I saw interviews with cardiologists in America who were saying, yes, 120 is better than 140, but there were no numbers. And these guys were keeping their powder dry till it was in the New England Journal of Medicine in the first week of November. So you know you're a little bit geeky when you're waiting for the next edition of the New England Journal of Medicine to come out. I knew it had to be there because when you have a study like this, and it's quite an important study because this is quite a big question for us. You know, we've got the patient whose blood pressure is 145, 142, 138. Well, what do you do? Is that 140? You know, it's that sort of stuff. So this has been a big question clinically, and it's pretty amazing they did this study. Now, there were a few flaws, and Matt pointed them out the other day. It was stopped after 3.2 years, but you can't keep these trials going when you get a mortality gain. There was a mortality gain. That doesn't often happen. So that was an end point. And it was a bunch of people with pretty high risk. So 20% of them had 17% of them had known CVD risk, and the average 10-year risk was 20%. That's way above our 15%. So these were people who needed things. And the final blood pressure after 3.5 years was 121 in the intensive group and 136 in the control group, they were randomized to a target. Okay, so this was the difference. So in terms of the intensive group, CVD rate was 5.2% in the intervention group and 6.8% in the 140 group. That's the numbers needed to treat of 61. That's a reasonably good NNT for a preventive activity. And it showed a difference in terms of death. So you had to treat 90 people to prevent one death. So if you reverse those numbers, 94.8% of people didn't have an event versus 93.3%. And sometimes getting these things in perspective for patients is quite important. I've learned never to use numbers needed to treat for patients. I mean, my colleagues have enough trouble with it. Patients just get completely flabbergasted. In part because, you know, people 70 or 80 in New Zealand often left school when they were 12. They're really quite innumerate. Interestingly, for the older people, NNT was 31 versus 61 overall, and I was a bit appalled that the Americans changed their threshold from 140 to 150 last year. That's completely crazy. I mean, if you're thinking about safety, that's one thing. If you're thinking about effectiveness, the older the person, the better bang for your buck. If you had to get a benefit, if you had a bunch of pills and you had to get a benefit in the next 5 years, you'd give it to almost the oldest people you could find. You know, it's certainly up in their 80s. Obviously, if they're 100, you might be wasting your time. But the biggest bang for the buck is, and in the high-vet trial, NNT was 6 to prevent an event in 5 years. Not many things we do have an NNT of 6. So for older people, they got more benefit. That's obviously an issue in terms of who you're going to treat. Is this going, John, or are you doing it? Okay, so the downside were, okay, so you had to give people 3 medications instead of 2, and so that's on top of my record, and Linda saw this patient in my practice of 20. She reviewed the notes and got them down to 18, so, and I'm sure you've got patients like that, so I had a very sceptical critical eye, and even you could only get it down to 18, couldn't you? 24% of people were on 4 medications in the intervention group and 7 in the control group. And then chlorthalidone, 55% in the intervention group and 33% in the control group. And for this trial, they preferred chlorthalidone because they're aware that in the United States, everybody's underdosed with hydrochlorothiazide. Hydrochlorothiazide is their diuretic of choice, and just about nobody's on more than 50 milligrams. So they specified, now the physicians had a choice in this trial, but they chose chlorthalidone. And those of you who know me know I have a little bit of a love affair with chlorthalidone. And I said that in an email to Matt Dawes one day. I said, you know, I have a love affair with chlorthalidone, and his advice was to get out more, so, which I thought was quite apt. So My kids think I'm a bit geeky, and I'm sure you're starting to think that too. Okay, so in terms of ACEs and ARBs, 77% in the intervention group and 55% in the control group. So naturally, there are a lot more drugs in the intervention group, and that comes up with one of the tables. So I'll just let you read that. So this is about the renal harms in the trial. This is where it's not well described, and I suspect it's coming out in another paper. I mean, if you're an academic, you have to milk this data for 10 years if you get an article like this. So I'll just let you have a quiet read of that. And as Matt said, that's an issue with ACE inhibitors anyway. Creatinine often pops up a little bit, and it's one of the things we need to remember is to do a creatinine within a month of starting, probably within a month of starting ACE inhibitor. And I've had 3 or 4 over the years pop up, and they probably have renal artery stenosis, atherosclerotic sourced. One guy, you can actually allow it to go up to about 25% according to up to date. I phoned Mark Marshall, the renal physician at Middlemore, and said, what's the acceptable limit for a raise in creatinine? He said, I don't know, have a look and up to date. And I said, well, I have, it's 25%. They had this guy, went up to 25%, so I watched him. And then it kept going up and up and up. And I seriously thought I'd put this guy into renal failure. It took about a year for it to peak and start. And he was a vascular path. And I thought I'd ruined this guy's kidneys, having followed what I thought was best advice. John, we're still not getting any ignition here. Am I doing something wrong? I'm going to push the button harder. Okay, so this was a table that Matt pointed out. Now, I normally don't get into methodological issues, but when you're doing a randomized trial, you power it to the primary outcome. Now, in a sense, when it comes to publishing, that's the only thing that matters. Everything else is collateral information. Now, Matt, and I'm going to email this to Matt, I'm not talking behind his back. So his concern was it didn't show any difference in terms of acute coronary syndrome. There were slightly fewer strokes than in the intervention group, but there was a lot less heart failure, and that was statistically significant. But there are a lot less deaths, and deaths from any cause. So you can see the problem here. Now, I've got a drug that I'm using for heart failure. I go to the secondary outcomes and I say, wow, look what it does for heart failure. But it wasn't what we set out to look at. So in a sense, that's the thing we should be talking about. The rest of it is interesting. It's all in the right direction. But the trouble with composite outcomes is you are sort of adding sort of apples and oranges and lemons and a bit of cake as well, and so it's a problem. So they said they were looking at the primary outcomes and CVD, and that's what they found. So I'm not too fussed about that table. In terms of the harms, there was more hypotension, which as you expect. There was more syncope and more electrolyte. In fact, the one downside of using chlorthalidone is you do seem to get more potassium and sodium changes. I sometimes think that's because it's more effective than anything else, basically. If it's effective, it has side effects. Serious falls were the same. Now, that's interesting. Now, you do have to remember the people who get in this study aren't fragile little old ladies, okay? They're probably, people will eyeball the people coming to the study. Anybody who looks fragile is going to be disappeared. Acute and kidney injury, 4.4% versus 2.6%. That may just be the rise in creatinine that comes with giving ACEs and ARBs. It may be no more. They haven't given any more information, and I suspect they're keeping their powder dry to get another publication. And James McCormick of the Best Science podcast, Without the BS, that's his thought about what that might be. Okay, so here again is just a little method. This is the Accord trial, and the other thing was there were no diabetics in the study, no overt diabetics. And I think that's because diabetics are a funny group. You can have diabetes and have the same risk as the rest of us, or you can have diabetes and be dead sort of in 6 months' time. So they put the Accord trial together with the SPIN trial. This was the people in Australia in an editorial. So that means this is the line of no benefit. So Accord showed statistically no benefit. That's Sprint, and that's the two together. So put the two together, and you get a better result. So I think it's an important study. It was difficult to do. There were some people in there who didn't actually have a blood pressure of 140, so if they're in the 140 group, they would have had nothing done to them. But that's even more extraordinary that they showed a benefit, because they would have had a lot of lower risk, lower blood pressure people in the trial. So my view would be, I think it's okay to aim for 120 if you think it's worthwhile. And my approach with this is to say to the patient, well, here's the numbers, and I'd quote those numbers at the beginning and say, you know, I say to patients all the time, I'm merely your advisor, you're the boss. Is it worth taking probably another pill for the rest of your life to have this 1 in 60 gain? I would aim for the higher risk and the older patients, and remember in the elderly, their risk is going up the absolute benefit is going up 1.1% per year, so in 10 years that's gone up 11%. I think you have to eyeball people and predict the ones who might have a hip fracture if you knock them over. But I mean, if you're 85 years old, breaking a hip's one thing, having a stroke is a pretty miserable thing. So I would advocate judicious use, would be how I would say. Diabetics is tricky, I think. The latest BMJ meta-analysis suggests we shouldn't go under 140. I think what's needed with diabetics is a big trial like SPRINT. I think the problem is there's all these little itsy-bitsy trials and they're putting them together. I think in the patient, on average, 125 to 130 is better than somebody spending their days at 140 to 145, and that's the sort of ballpark, I think. If somebody's wandering up in the 140, 150 range, I would be inclined to try and bring them down. Matt does like chlorthalidone, and if you listen to the podcast, he points out that you do get the biggest lowering in blood pressure, and we've just put a thing in the New Zealand Medical Journal, which we're hoping they'll accept. It's got more outcome evidence than any of the other antihypertensives that are available. In fact, bendrofluozide has only one study, and it isn't effective other than when combined with potassium-sparing diuretics. Okay, Linda.
Oh, right. Oh, thank goodness I'm not going to be saying that we shouldn't be using chlorthalidone or Bruce would be getting a divorce. But I'm going to go through another sort of old thing for the people that are about my age when beta blockers were first or second line for blood pressure. But it seems pretty much now that they've been superseded. How hard were you meant to push that? The issues. So basically when we're looking at these sort of older medicines, and that's what we're going to be doing for some of these sessions, is looking at older medicines as well. Now, if we have a look at beta blockers and we look at them for heart failure, actually I'll just go, no, I was going back, but don't worry. Oh, okay. John, I'm just going to go like this and think in the future. That way? Okay. Other way? Okay, sorry about that. Okay, so if we're sort of looking at beta blockers here, heart failure, obviously they're really good, and we're still disappointing to a great extent that we don't have more people on beta blockers with heart failure. So definitely there's a good number needed to treat in terms of mortality for that. Things have cropped up now about, it doesn't matter that we've got different properties of our beta blockers. So the usual thing would be to stick to the ones that have actually got evidence-based. And the good thing about bistoprolol now is that there's different excretion methods there, so we're not so worried about the interactions with the beta blockers. So heart failure, pretty straightforward. If we look at myocardial infarction, this is something that's coming through a bit more now. And so in many cases, it's only for the year, an absolute sort of max of 3 years, but generally for 1 year post myocardial infarction if there is no evidence of any heart failure in there. And people think, oh my gosh, you know, because we're used to say post-MI you're going to be on a beta blocker for life. So we have to have a look at why did that actually change. So one of the reasons that changed was because most of our studies with beta blockers post-MI were small studies. They're a little bit old, but they were done in an era before we had reperfusion, and also they were done before we had statins. So of course with reperfusion happening now and getting so many more stents and looking at using statins so frequently, post-MI, the risk is actually reduced, and so the benefit of the beta blockers is reduced. So they have now come to much of the conclusion that if your patients can't really tolerate that beta blocker after a year and they have no signs of heart failure, or they've had an echo, then it's actually okay to pull back on the beta blocker and stop it. So that's something that's quite new. The other one, we used to have this concept of when someone had angina, and this is what I used to think was angina, we know that beta blockers are really good post-MI, so let's get in early and give them a beta blocker. It's becoming quite clear that it really doesn't matter whether you use a beta blocker, calcium channel blocker, or isosorbate mononitrate. So then this is the other one that you're allowed to use clothalidone, but don't use beta blockers, generally as first line. The reason for this, again, they're saying, but we had all these wonderful studies and we're so evidence-based. Why aren't we going to use beta blockers? It does appear that it is to do with the reduction of the central pulse pressure, and I fought this for some time, but I think we've got to concede to it. And then you had a look at some of the original studies, and it used to always be beta blockers and thiazides, that probably the main effect was due to the thiazide. So we're back to using, and that thiazide generally was clothalidone. So really, I think we're finding the conclusion now is that when it comes to people with high blood pressure, you've got your three other agents, clothalidone and an ACE inhibitor and calcium channel blocker. And then you might consider using the beta blocker. And of course, after that, perhaps the spironolactone. COPD, yeah, it is of benefit for people with heart failure. In fact, they tend to be of benefit for people without heart failure and COPD as well. And migraine, it's a little bit ambivalent. Again, we used to think beta blockers were good. So really, on this one, the take-home message is absolutely, can we please have more beta blockers in people with heart failure and even in COPD, but we don't really want to have them for long-term in myocardial infarction and angina, toss it up, make your own choice. Same with migraine, and we're really not going to be using beta blockers. The question does come up, though, is should we withdraw them? And if you've got someone on a beta blocker for for high blood pressure, the chances are that you could actually switch it to a far more effective agent, which we won't name. And how do we actually withdraw it? So I think the main thing to remember about withdrawing beta blockers is they have to be quite slow, and we are talking, if you've got the time, titrate them down over about a month, if not longer, because we saw the rebound effect of beta blockers being dropped suddenly in one of the, wasn't the Merit heart failure, it was one of the metoprolol studies. So do remember to titrate them down slowly if you want to get rid of them, but it's probably a good idea to do so.
Do you want to say a word about atenolol? Probably just say no now.
Yeah, I was going to say...
Should we take people off atenolol? Because the problem is they've been on it for 30 years and suddenly you rock up and say, well, it's latest evidence suggests we should stop that, and I can imagine...
Yeah, and you're going to do it slowly. If you really needed the beta blocker, I'd be switching them to bisoprolol. The thing about atenolol is it's water-soluble, so it's excreted renally. As they get older, you're going to need less of a dose anyway. But yeah, I'd hope we're certainly not using atenolol, and I'd certainly hope that we might change as well.
And the issue is the central blood pressure thing. So atenolol reduces your peripheral blood pressure, but not your central. Sure. So the pressure in your coronary arteries isn't changing. That's what. And in a few years' time, we'll be measuring people's blood pressure, and we'll be getting a measure of your core pressure. There are now machines, and we had a trial of one about 5 years ago in the clinic, which actually gave you people's core blood pressure. So they measure, you put this electronic machine on, and it actually tells you the core pressure. And we had a couple of people at very high cardiovascular risk, and they had very high core pressures. And there are certain drugs that seem to lower core pressure, but that's something that's probably coming in the next 5 to 10 years. We won't just be measuring blood pressure, we'll be measuring core pressure.
Because it is quite awkward measuring blood pressure. It's one of the most variable things.
Well, that's the whole issue with the sprint trial, isn't it? Blood pressure dances up here, but you want it actually dancing down here on average. But, it's hard that we ever make anything of it, except that when you go to China and look at 1 million people, it's just a straight line going up. There's no threshold. Okay, so we're changing to gout now, and this is a real case. This is where I got onto the 7-minute treatment, acute treatment and prevention of gout. This 40-year-old Tongan man came limping into my office, and there's a gout limp. There is a gout limp. And these are usually big, tough Maori or Pacific guys, and they can put weight on their foot, but it's pretty damn sore. If someone's broken their leg, they jump, they hop, and if they've torn a tendon, then they usually hop. And it's quite a distinctive thing. So I don't know if I'm looking at the ethnicity or I'm looking at the limp, but there's definitely... And Susan Reed, who's a Maori woman, she agrees there's a gout limp. And I'm sure you know what it is. So no history of injury. He feels well. He ate mussels the night before, doesn't drink alcohol. He's had 2 recorded gout attacks. He's been given diclofenac on 2 occasions, and he smokes 10 cigarettes a day. Now, this is on a Saturday morning in our after-hours clinic, and I know this could take half an hour to get this guy onto acute treatment and then allopurinol. But anyway, we're in the midst of this randomized trial, starting people with allopurinol during an acute attack. And Nicola Dalbeth actually said yesterday, no problem with starting allopurinol during an acute attack. It's no longer verboten. But with the method I'm using now, with blister packs, it doesn't matter when you start it, actually. So anyway, we're doing the randomized trial. I suddenly thought, the pharmacy downstairs makes up the packs. I can give him blister pack 1. 7 minutes. Got this guy onto allopurinol. So these are his vital signs. So he had pain and redness in the right MTP joint. His vital signs are normal. Now that's pretty important. We get the medical students in our clinic to do vital signs on any acute presentation, because in our trial we had one person with a temperature of 37, and that was an exclusion temperature, and he had a infection in his bone. So vital signs are really important to rule out septic arthritis. So be very, very twitchy about somebody who's got a slightly raised temperature for whatever reason. It's probably not a good idea to give prednisone, which is what we have in the blister pack. No other painful joints. Blood pressure 180 on 120. It was still high later on, but not as high as that, and his BMI was 45. From earlier blood tests, this is often the case, his creatinine was normal, and he had a uric acid of 0.58. And remember, the target dose is less than 0.36. So the blood test doesn't tell you they've got gout, but if his serum uric acid normally was less than 0.6, that would probably mean he didn't have gout. In terms of, so these are the diagnostic factors. Now, you're pretty sure that guy's got gout, but here's why. Actually, one of the best rule outs is a gout that's that should be, a uric acid greater than 0.35, because if your uric acid is less than 0.35, you almost certainly don't get gout. Certainly if it's below 0.3, you should never be getting gout, or you should be reconsidering the diagnosis. He's male, previous attack, joint redness, MTP joint. He actually has a cardiovascular risk factor, and the onset was with 1 day. So that's the order of the most important to the least important. So he's got really all those. So I'm pretty confident he has gout. I don't need to stick a needle in his toe. I don't know how to do that anyway. And interesting, Peter Gow at Middlemore doesn't put needles in joints anymore anyway. So it's sort of, and I always think patients would have a panic attack if you came at them with a needle. Although it shouldn't hurt, because it's pressure that makes the pain with gout, not sharpness. So the other factors in him, he almost certainly carries the Pacific gene. I tend to find with Maori and Pacific patients they've either got gout running through the whole family or no one's got gout. It's pretty clear cut. If you've got somebody and you think it's gout, then they're almost certainly got a relative. And I often find it quite important to say, well, are they under control? Because often those people aren't under control. They're not on prophylaxis. He wasn't septic. There are no other joints, and so no need to aspirate. I'm pretty happy he's got gout. Am I pointing at that one? Where am I pointing at? Over there. Okay. Sorry. Okay, so he had reasons. He'd had 2 previous episodes within the previous year. And I say to these guys, my sales pitch is you can eat as much, if you take allopurinol every day for the rest of your life. Now imagine this guy's 20, and I'm saying you've got to take a pill for the rest of your life. You know, he's going to think, I'm completely out of my mind. And I had a guy the other day like this who'd had 3 attacks, age 22. And I said to this guy, I said, you know, you could prevent this. This is awful, isn't it? You could prevent this if you took a pill every day for the rest of your life. Does that idea excite you? No, not really, no. Okay, well, if you take the pill every day for the rest of your life, you can eat as much seafood as you like and you can drink alcohol. Would that make you interested in taking a pill for the rest of your life? Yes. But this guy's got a couple of strikes. My 22-year-old guy's got a few strikes. He can't read. He doesn't have a mobile phone, And I've been stalking this guy to see if I can get him onto his allopurinol. And I phone up his family and they say he's just taken a job where he's driving to Gisborne every day of the week. So you can, and he's in the early stages of his gout. This guy's going to end up at 60 seeing a rheumatologist who when he goes on allopurinol, the rheumatologist says, see, it's easy. It's not easy for us, and I think we have to remember to do these sort of things. So my 22-year-old man, the Tonga man, was happy to take that because he's 40 and he's had a few. Sorry. Thanks, sir.
Right.
Okay, over to Linda.
So, yes. I used to, when I was working next to Bruce, I used to tell that to the patients, and I said, but whatever you do, don't tell Bruce that I told you you could take your muscles when you have your allopurinol. One patient came back to me and he said, Bruce says exactly the same and not to tell you. So anyhow, this is sort of a bit of a changed message, and gout is still major. I mean, I've heard that Counties Manukau is the gout capital of the world, and I come from Porirua now, and we're pretty much competing with you. It is really high in our Pacific people, and if we had a look at the admissions to Middlemore Hospital, and it was something like 167 people over 5 years, and that was primary gout under 65. So it's even worse for people that still had gout or over 65. It is a problem. And one of the things was, I think, my past sort of like 10 years ago, we were telling people that if you have renal impairment, don't go above 100 milligrams of allopurinol. So I think I feel very guilty that for many people we've actually stopped them having the right dose. So this is really reiterating what Nicola Dalbreth was actually saying, because we were treating to a laboratory result as such. We weren't treating to the target serum uric acid one. And I think just to really say that things are changing, and I still see sometimes people saying, but they've got renal impairment. We can use really high dosing. And this also sort of came up, Nicola would be saying 1.5 milligrams per 1 unit of EGFR. I can't calculate that very well. So basically it comes down to this is the sort of dosing that would be going up to. So it is the slow titration. We're worried about the hypersensitivity syndrome, but in reality, it's the rate in which you start the allopurinol that's going to increase that risk. It's not the dose that you get to. So particularly I'd imagine in counties and some of the ones we have in Porirua, those doses are going to be 450 or 600 milligrams. So we shouldn't get worried about that. So putting that up, this is, Bruce is going to tell you about the blister packing, about how to do this, because you can imagine trying to explain to someone, particularly if they have English as a second language or they have problems with reading, it's a little bit complex to say titrate up every month and that sort of thing. And the other one is to make sure that we do cover with colchicine. And Bruce will go over that. The one I do say though, and I always have to remember, is stop if you get a rash. And although there can be 4% of the people who get a rash due to allopurinol, we don't want to miss the one that is the 0.4% that will get hypersensitivity syndrome. So that's really just to say, we no longer worry that much about renal function, and it's the rate that you start allopurinol that's the problem. So Bruce has solved this, and I'm quite fascinated.
Okay, well, the blister pack has gone through a couple of iterations, and there's been a pilot study in Manaia. Is anybody here from Whangarei? They've probably all gone home, I think. They've been working on the blister pack, and in Nelson, they've been working on the blister pack. So essentially, there's 3 packs. So depending on your EGFR, if it's greater than 60, you get pack 1. If it's between 30 and 60, you get pack 2. And if the EGFR is less than 30, it's recommended you discuss the situation with a rheumatologist. But if in the Chatham Islands, you would just get them on with it, basically. Now, if you go to gouthappyfeet.com, all this stuff is there. It's got the prescriptions, and it's got some fantastic. It's got the Pharmac booklets in Tongan, Samoan, and English, and it's got a very good one. The best one's actually in English. It hasn't been translated yet, which is on gout. It's about 6 or 7 pages. So the only way you can get the Pharmac ones now are on our website. So it's gouthappyfeet.com. So in the non-diabetic, they get given prednisone 40 milligrams to 5 milligrams over 2 weeks. So that's why you've got to be careful not to have somebody, even with the slightest hint of it being septic. If they're diabetic, then you give, this is the Manurewa one, 500 milligrams BD for 2 weeks. If the eGFR is greater than 60, below that, they suggest discussing with a renal physician. They're just concerned about NSAID toxicity. I suspect most renal physicians would say go ahead until you're getting very low eGFRs. Or you can give a lower dose of prednisone. I have to say myself, I feel pretty comfortable giving prednisone to people who've got diabetes so long as they're not badly controlled. I think anybody, certainly people on insulin, you would have to be very careful. But I've had no problems with that personally. Okay, so pack 1, in terms of the allopurinol, so the packs have prednisone, allopurinol, colchicine, or naproxen, allopurinol, colchicine. And I don't think you can start those 3 medications on anybody. I defy you to see your GP and get told to start 3 medications. I think it's too complex, and it's even more complex. You know, my guy who can't read's got a job in Gisborne, doesn't have a mobile phone. I'm having to call him in the weekends to make sure he stays on it. He's my project for the next couple of months. I'm just trying to work out how hard it is so I can tell the rheumatologist it ain't that easy when you're seeing people early on in their journey. Colchicine 500 BD, that's to prevent the flares. Nicola Dalbeth would say maybe go out to 6 months with that. Or pack 2, 50 milligrams of allopurinol daily with colchicine 500 daily. You don't need to go above 3 colchicine a day. In fact, ironically, 2 is better than 3, and you get more side effects with 3. And then pack 3 is the lowest dose, so that's 50 milligrams every other day, and colchicine 500 micrograms every other day. They need a uric acid at the end of the pack, and then an up titration with colchicine. And the target has to be 0.36. If they've got tophi, Nicola suggests going to 0.3 because that sort of sucks the uric acid crystals out of the tophi. And the allopurinol, 600 or 700 milligrams, it doesn't do any harm to the kidneys. It was almost a gem, actually. There's quite a bit of evidence come out of that. I guess I sort of grew up thinking that allopurinol harmed the kidneys, and that's probably where your thing came from. And it's a very difficult message to turn around. If they're not getting anywhere on 600 or they get a rash, then febuxostat is the alternative. It's a 2-step. It's 80 and 120. It'd be nice if that was available because it's just a 2-step titration. And a lot of people get to target with just the first step. You still have the flares, though. You're taking the colchicine to stop the flares. So it's a pretty complex cocktail, just the medicine, let alone the psychosocial, behavioural stuff. In fact, what we're doing in our clinic, and I don't know if Tanner Fishman is still here, no, is looking at getting the nurses to case manage these patients for 2 years, phone them up regularly, post out prescriptions, post out lab tests, because these guys don't like taking time off work. You know, it's an increasing thing, I think. I think the employment climate's got so tough. If you're in sort of a manual job or a factory job, it's pretty hard to tell the boss that you're going to take 2 hours off to see your GP. You know, these guys think they're going to lose their job. Now, legally they can't do that, but I think they feel pretty vulnerable. So we have to make the right thing the easy thing to do, and we can't wait for them to come in. That is just not going to happen if you want to get them onto allopurinol. And of course, the longer they go without an attack, they're going to think, well, I haven't got gout anymore, and you know, the issues of stopping. So that's why case managing people out to 2 years, we think, is going to be what's needed. Because even the blister packs on their own aren't enough. I've got 2 guys now I'm stalking, and neither of them have finished their blister packs. Things went wrong. And yet I explained it carefully, gave them the blister packs, and within a month, both of them are, you know, it's not working. So it's very complicated. So monitor by phone, confusion's likely. And even posting things out is a bit tricky, actually, because I was recently involved with Rinky Murphy in recruiting patients, and we posted letters out and nobody phoned in. And I phoned one guy up and he said, well, there's 3 families living in our house, don't post things to us, because, you know, somebody else picks up the mail and they're just as likely to pick up my stuff. So I think if we have our sort of middle-class view of posting things out to people and they're going to take it out and read it and look at it, I don't think that happens with a lot of these patients. You have to have a relationship with your pharmacy. The pharmacy has to know what the formula is. So our pharmacy, the two pharmacies in Manurewa, have our prescriptions. My practice is just down the road here. The pathways are on the health point pathways for acute. The pathways, unfortunately, don't use the blister pack, so that's a little issue I'm trying to work on, but at least they're being used in Whangarei and Nelson. So gouthappyfeet.com for to make up the packs. So you give that to your pharmacist and then they'll make up the packs. Now our pharmacy, amazing, they bring the prescriptions up to me to sign. I just write gout starter pack 1 and they send the prescriptions up to me, which I sign and we send back down to them. So it can be a very fluid thing. Okay.
So just a couple of quick things. Renal function is really important, particularly when it goes off. But we are changing some of our minds, and this is just a really quick one to talk about metformin, because people were looking up the data sheet, as you should. But the data sheet for metformin was actually telling us not to use metformin when creatinine clearance was less than 60 mils a minute. And I'm sure many of you have been using metformin down to 30 mils per minute, which is perfectly fine. So this is really an official endorsement that says that people were missing out on the benefits of metformin and that we are less concerned now about the issue of renal function. So this was just a quick reminder that really there's a bioavailability of metformin, so the maximum dose is generally say 2.5 grams a day, so there's no point going up to really high doses, but then basically we can go down to 30 to 45 mils per minute. We can still be using metformin. Diabetologists and renal physicians will probably use it less than that, but always get their opinion first, just to make it easier. So our risk of lactic acidosis is not as bad as we'd thought. The other one on that, just thinking about changing times, a quick one, because paracetamol's been our favourite medicine. We'll use it 1 gram 4 times a day, and for heaven's sakes, take it regularly. And we spend a lot of time telling people to take it with breakfast, lunch, dinner, and bedtime. And now suddenly we're finding that it is actually perhaps a bit more toxic than we thought, and maybe it's not as effective as we thought. So the effect of paracetamol could possibly be more to do with a sort of placebo effect. And we're going to get on to spinal pain with Bruce, but this is really osteoarthritis and spinal pain. So let's just look quickly really at the increased toxicity, and this is one of the things that is, we still have children with basically paracetamol poisoning. We've had liver transplants required because of that here in New Zealand, and it's not necessarily an acute overdose, but it's children that are taking it chronically. And so we're sort of giving it, and I've started now having a little comment, and I don't know how the pharmacist put it on the label, to be quite honest, but when I put it on, I say, this should not be used for your child for more than 2 days in a row, because if that child has still got pain, or fever, if they're using it for fever, but if they've still got pain, then they need a medical opinion. They need to see a doctor. And what was happening was these kids, from 2 of the cases we'd seen, were just consistently getting paracetamol. So it's one of those things that if a child has pain for more than 2 days, don't keep using, or tell the parents not to keep using paracetamol, but to actually get a medical opinion. And I think that's probably quite an important thing. Also, in the frail elderly, there's good evidence now. Again, I feel guilty at the, let's just give everybody 4 times a day paracetamol, that they are at increased risk of hepatotoxicity because they're not doing the second phase metabolism so much. And on the risks, there was also asthma that people have probably talked about, and GI. And to remind people, there is an interaction with paracetamol and warfarin. So, dubious adverse effects. So just a reminder, for adults now, we would probably be getting down to 1 gram 3 times a day, particularly if they're frail, if they're under 50 kilograms and they're malnourished, and for those people that have a high alcohol intake, if they're on warfarin consistency. And then just to remind you about the children there, tell the parents that they need to see a doctor. It is a free visit if they're using paracetamol more than 2 days, rather than just to keep going with that. And also, I'm conscious of this where we are, better to use ideal body weight for children rather than actual body weight, because we certainly, where I come from, have quite a few large children, and they've got greater risk of toxicity if they're malnourished. And the other one is, I know that you get paracetamol and let's give it and the whole family take it, but it is useful to use the lowest strength, mainly because it's hard to measure small doses, and the more you add, the less likely they are, the bigger the volume you need, the less likely they are to overdose. So, seeing as we can't use paracetamol for back pain anymore.
Well, I think paracetamol is the most commonly used drug in the country, actually. There's a thing in the
is.
paper.
Right
We have a nice little thing, thanks to Karen Hoare, who's sitting there. We had a critical event in our clinic, and she drew up this thing of the 2 doses of paracetamol for kids and their weight beside it. So this one's in orange and this one's in red. And so paracetamol no longer comes, it comes in white and orange, I think. But it's just an immediately visual thing, and it's much easier in doing a calculation, and you got it right. So I should perhaps put that up on the Goodfellow website, yeah. Or email me if you'd like a copy, and I'll email it to you. I'm sure, Karen, you'd give your blessing to that, to be given to the world, knowing how you deal with the world. Okay, so this is not an uncommon problem, I think. A patient comes with back pain, no particular injury. You wish they said, I injured my back, but they woke up in the morning with it, and no amount of probing can get an accident, and you think, oh my goodness. Pain going down to the right thigh, this is a real case. So I give this man, he's a 40-year-old Maori man, NSAID and paracetamol. He's unable to work, he works in a warehouse, it's a heavy job, there's no red flags. See him a week later, still has severe pain. So I increase the ibuprofen to 2,400 milligrams daily, and I add orphenadrine, which is Norflex, a so-called muscle relaxer. Very few randomized trials on this drug. There are randomized trials showing other muscle relaxants work, but this is the only one we've got available. So this is my I'm getting desperate drug, okay? So I'm sure the rest of you know what I mean. I see him 1 week later, still has severe pain. Add codeine up to 90 milligrams TDS. He's getting really stressed about not working. He's one of these guys who's worried about losing his job. The boss is on his case. He's really getting pretty worked up, and he's one of these guys with a good pain threshold. There's no concern about malingering here. This guy wants to get back to work. So I see him 1 week later on a Saturday morning. These things always happen on a Saturday morning. He's no better, very stressed about work. So do I give him opioids? And I'm really reluctant to give people opioids, because you know what a mess they've got into the United States with oxycodone and Canada. I mean, it's just... you wouldn't want to be working there. It just sounds like a complete nightmare. Or give them steroids. One of my colleagues gives oral steroids. And I was aware the evidence isn't wonderful on that, but I gave him prednisone 40 milligrams for 5 days. Saw him on Monday and he was much improved, and he was feeling ready to work. And then 6 weeks later, he was completely better. So whether it was a great placebo or not, but anyway, just looking at a bit of the evidence, I have a family member who had a CT-guided steroid. They have these things where they stick you in a CT scanner. They do an MRI and see where the nerve's been damaged, and they stick, I don't know how many you had patients do this, they put you in the CT scanner and put this catheter in. They find the bit that hurts, and they put local anaesthetic and steroid in, and this relative of mine had 2 periods of 6 weeks with unremitting sciatica relieved. The evidence for steroids is mixed. The randomized trials would say on average, it doesn't work. And so the CT scan, it comes in through the foramen, it comes in laterally, and I'm going to get one of the Mercy radiology people to come and talk about that. This was a photograph they gave me. So that's going in through the foramen, under the scanner, and actually it worked because they put a bit of local in, so the pain actually goes away immediately. So the patient has pain-free for 3 or 4 hours until it wears off. So it's pretty amazing, and I've had a 94-year-old friend of mine had this, and it fixed him permanently, and he was sort of in terrible pain. So this is a randomized trial. It was in JAMA, and this was, I don't know if it's been a gem. I've been thinking of making it a gem. And these were patients with sciatica below the knee and with the MRI showing a disc lesion. So, of course, we see these patients and there's no way we're going to have an MRI when we do this, but I figured my man had something was squashing his nerve. less than 3 months, and they gave these people prednisone 60 milligrams for 5 days, 40 for 5 days, and then 20 for 5 days. And this is what they found. There's a thing called the Ost-Westry disability thing, and it's about function and pain. It's a funny old score. But at 3 weeks, the Ost-Westry score was better in the prednisone group than the control group. And at 52 weeks, that had even got better. But there was no difference in pain. So better in function, but pain was no better. So at 3 weeks, the Ost-Westry score had gone to 37 in the placebo group and 32 in the control group. Now, that won't mean anything to you, and it doesn't mean anything to me. And I had a look at the Ost-Westry score, and, you know, it looks like a reasonable pain score. There were more adverse effects to having the prednisone, problems with sleep, appetite, and nervousness, but there was a benefit. And for those of you who are getting old and achy, 5.5% of people in the intervention group had joint pain and 11.4%. So I think I had the elixir to old age pain. So if you're prepared to put up with steroid side effects and have cataracts and osteoporosis, you can get rid of those achy pains. I must admit, when I take anti-inflammatories, my body feels fantastic, and when they wear off, it feels awful. So I think I just thought that was an interesting benefit that was. Okay, so I think oral steroids are an option when you're desperate, and I was desperate, and this guy was desperate, and I think it's a hell of a lot better than putting this guy on opioids, which we know only work for acute pain. They're not good for chronic pain, and then these patients get on it, and then they're addicted for the rest of their life, and then you can't get them off, and then they get depressed. You know, I mean, you'll have these patients, and you wish you'd never put them on this stuff. This is eyelid eczema. This is some advice I got from Paul Jarrett, because we had a patient in our clinic. And she was sent to me because she had this problem with her eyelids. She'd stopped using makeup. She had 2 kids. You know, that phase of life when you're pretty desperate, you've got the 2 kids, and life's pretty busy. And she'd been given hydrocortisone cream, and she was going crazy. And she'd seen a bunch of doctors who wouldn't give her anything stronger. And I think it's this thing that we come out of medical school scared of steroids. Now, steroids are okay if you use them for short periods of time. And I gave her some mometasone, and she emailed the next day and said how great she felt. So enormous gratitude. And I ran this by Paul Jarrett, and he thought probably mometasone was a bit strong. And this was his thing. He's done a podcast on topical steroids, if you like podcasts. He would suggest 1% hydrocortisone because of better penetration, and then clobetasone. So that's the old Umivate. And that's a level 2 steroid, not clobetasol. Don't get that confused. That's Dermavate under the old names. So it's clobetasone. He would use that for a short period of time. So clobetasone for 5 or 7 days, or mometasone. He also has this thing about need to apply things thickly. MedTech defaults to apply thinly, and he says you apply so thinly, you literally have got a mole per sort of square inch, you know, or a molecule per square inch. And, but also whenever I write a prescription for steroids, I say not to be used on the face of people, because I've seen 2 patients in my career who started popping on their face, and it sort of tidies things up if you've got a little bit of damage, and then they end up with steroid damage. So I'm very gun shy, and I never put potent steroids on the face for more than a couple of weeks. But short periods of time. And I think, I explained to this patient, you can't use this all the time. If it doesn't go away, you might want to have to look at tacrolimus, which is about $50. So that's a, what is it? It's a...
Pharmacy only?
Sorry? Tacrolimus. Forgotten what they are. They're these anti-inflammatory...
immunosuppressant, yes. Yeah,
calcineurin inhibitors.
Yep, sorry.
Yep.
Like
okay, so it's $50 for a little tube, but you don't need too much, but that will prevent it. And you have to be a bit careful with long-term steroids because of the issue of cataract. So I thought Paul summarised that quite nicely, and Paul's a great teacher, and there's also a webinar with him. We started the webinar, it was supposed to be on the Red Rash Made Easy, and we got about to slide 5 and the questions just started coming in. And I think you could keep a dermatologist talking to primary care clinicians all day and all night for 2 weeks. We literally just had to call the show to an end, so we're going to have more of him. But Okay, COPD, and we're still on steroids.
Still on steroids, but this will be fairly quick because it really is confirmation of what you've come from what a lot has been happening with John Colby in that this morning. So basically there's the heterogeneity of COPD. If you've been through that, COPD is on a continuum and it's certainly not simple like we thought it might be. Of those sort of phenotypes, there's asthma and COPD overlap syndrome, which John Colby said he wasn't sure about, but put it this way, that's people who have had asthma when they were young, however they got to then have COPD. Eosinophils, again, and those people tend to be frequent exacerbators. That's coming from the evidence, and that really is only 20 to 30% of people with COPD, and as John mentioned this morning, there is something like 80% of people on with COPD who are on inhaled corticosteroids. So we're sort of looking at quite a severity there. Basically looking at the issues, and that's saying about the benefits of inhaled corticosteroids in COPD. There's a lot of systematic reviews. The evidence is inconsistent, and that's because we've taken average mixed up populations and tried to get some sort of view of that in particular studies, and as he mentioned this morning, we've probably taken those that are frequent exacerbators. There's certainly no mortality benefit that's been found from them, and if we reduce exacerbations, it's pretty small if we look per person per year. And we've had confirmation of that by the withdrawal studies, and there's been a meta-analysis, there's been a wisdom study, and then a Quebec one, where basically, if we have a look at it, you can withdraw inhaled corticosteroids from people with COPD generally and not get a deterioration. So going through the risks that most people will be aware of, you know, that whole bruising, the main one is looking, systematic reviews actually relates to those with pneumonia. So if we have a look at those ones, there's a high rate of pneumonia, and I think John's reanalysis of the TORCH study this morning showed that really the number needed to harm keeps sort of going up a bit over like 3 years, and the number needed to treat is getting, the number needed to treat is getting bigger, and number needed to harm is getting smaller. So basically it's an indication that we're getting a lot more pneumonia. And again, there's been 3 studies with withdrawing the inhaled corticosteroids, and we found that pneumonia reduced as well. So I think we're getting, it's quite real that pneumonia is a problem. The one coming up is eosinophils, and this also, it does come from the Auckland Health Pathways. So while people are still worried about that, there's quite a bit of data out there linking the eosinophils with exacerbations. So there's quite a definite relationship going on there. And the post hoc studies, there's 2 post hoc studies to do with inhaled corticosteroids, and when they separated the people into eosinophils and non-eosinophils, the people that benefited from the inhaled corticosteroids were those that had higher eosinophils. So I think we are sort of just working on the fact that we've been using inhaled corticosteroids far too much. So quickly going on really to the take-home message on this one is that we're moving from that lung function-based sort of decision support that we used to have, like, oh, it's an FEV1 less than 40% or whatever, then they're very severe, then we have to start using these medicines. We're moving really away from that and looking more at the type of COPD and being more patient-centred about it. So this is very individualising treatment. The first thing is to optimise the LABA and the LAMA. And I must admit, I was taken by surprise to a great extent on the 1st of March when suddenly we have these wonderful plethora of in both the LABA and the LAMAs together in one inhaler. So there's no excuse now not to be using that first up when we're doing COPD and not having to use the inhaled corticosteroids with the long-acting one. So if you're doing this, now, as John would say, this is not necessarily evidence-based, but if you look at the eosinophils, that's going to give you a better feel in your own experience about eosinophils and COPD. So it would be checking the eosinophils, look at the exacerbation rate, and look at whether they've had a history of asthma, and then start using the inhaled corticosteroids only if they're frequent exacerbators, and that's like 3 a year or more, and if they've got eosinophils. Trying the pneumococcal vaccine. The other thing to do in this one, because we've got such a high use of inhaled corticosteroids, is consider withdrawing them. So again, optimise the LABA and the LAMA, doesn't matter which one it is, remembering that you don't need the inhaled corticosteroid and the LABA. optimise that, check the eosinophils, and then look at the exacerbation rate and withdraw over 3 to 6 months. Now, some would say you can just stop it, but I think when they showed in the wisdom study, it is better to withdraw it over 3 to 6 months. So
the impression I got from John was that the trial showed a LABA plus a LAMA. You could get people off their corticosteroids.
Yeah.
So I had to chuckle at this. You think of all the effort the respirologists got us to put people onto steroids, and now they're putting all this effort into us getting off. It's
things change year by year.
The other thing I'm interested in, I have a patient who I'm just considering withdrawing because she was admitted to hospital with pneumonia. She gets wheezy exacerbations, and her eosinophils have been consistently greater than 0.3. They've been 0.4 for years. So it'd be interesting to know how stable people's eosinophils are. But looking back on her, every blood count she's had. So she's got all sorts of other problems as well. But the thing with the pneumonia is they don't tend to kill people. So mortality is better on inhaled steroids, but the mortality...
The DHB will not appreciate you saying that because they go to hospital and they cost money.
Well, John says they actually have very, very few deaths. His talk was fantastic this morning. If you get a chance to hear John Colby. Okay, so antibiotic horror story number 1. This is my friend Steve and Joan Moyer. They live in Los Angeles. And so I've got my arm around Joan, and Steve's got his arm around the dog. It's a sign you've been married for a long time. So anyway, he has a concierge GP. He pays $550 US to her every year. So does his wife, and that gives him the chance to phone her up anytime he likes. And she'll answer the phone if she can, and he can send an email and she'll get back to him with 24 hours. And he says to him, I have this concierge doctor, it cost me $50 a year, and she nearly killed me. Anyway, this is how he nearly killed her. So he's had Crohn's for 50 years, and he goes and sees her, and at the end of the consultation, he says, I think I've got a bit of a sinus headache, at which point she gives him some amoxil. Now, 2 weeks later, he has explosive diarrhea, phones his GI physician, which is what they do in the States if you get diarrhea, and his first thing was, have you had antibiotics? And of course the answer was yes. So anyway, he had C. difficile, had 2 courses of vancomycin, and had persisting symptoms. And apparently with C. difficile, I'm going to get Alan Fraser to talk about this next year, you don't retest. If they get symptoms, and if the symptoms keep coming back, it means they've got C. diff. So he ended up having a fecal transplant, and now he's developed lactose intolerance because presumably the faeces he's got were from somebody who's lactose intolerant. And he's been told this could take 3 to 6 months. So a bit of a saga, eh? Anyway, there is some stuff. Now, you can have your fecal transplant fresh or frozen. And it makes no difference which you have, but it means with the frozen you can bank them. I was just talking to Mark Thomas this morning, and he was telling about the first one they did, and this guy's partner brought in this little lunchbox with this fecal matter in it, rather full, and they gave the whole lot to her husband who had C. difficile. So I said, how did you do it? They don't know how much to give people, but they gave the whole lot. They do give it rectally, not oral. I thought they put a nasogastric tube in. But if you're involved with me needing a fecal transplant, I want the frozen one, please. And if you're going to add fries to it, I don't want the amoxil with it, okay? So anyway, antibiotic horror story, augmentin horror story number 1. This is a patient of ours who had a mastectomy some years ago, and she had a staph, and she was given augmentin, and she got C. difficile, and she ended up on a ventilator in Middlemore. So you wonder why I hate augmentin. It's a great drug, but and she did need it, I have to say. Whereas this guy got it for, I think, a bit of a chesty thing, and he had liver failure, ended up in Middlemore. So, and I don't see a lot of patients. I don't do a lot of clinical work, and I've had 2 on my watch. So I didn't, and they weren't given augmentin in my office or our office because we actually have this thing whereby if you want to give augmentin, you have to ask permission of somebody else, one of the nurses, one of the doctors. And I had a 50-year student with me one year, and I turned to him and said, oh, can I give augmentin to this patient? He said no. Okay. So I gave flucoxacillin, and everybody was living happily ever after. So, and just remember, 50% of New Zealanders get an antibiotic every year. I think we really have to get our act together and withdraw that, because the more you prescribe, the more medicalised people you get, and then they want antibiotics and they think you're the useless doctor because you're not giving the antibiotics. So that's melatonin.
Right. This is actually...
Now I've given you sleepless nights. Now
They give me horrible thoughts about fecal. Oh, yeah, it's the reason for not being a medical person. This is another sort of fairly quick one because I'm not into supplements or anything like that, and the whole melatonin thing, I'm thinking, oh yeah, right. Now this came from Bruce first of all, and then one of the GPs in the practice I'm at asked me about it, and I'm thinking, oh yeah, indication creep, typical, you know. And that was the use of melatonin in autism spectrum disorder and in ADHD. Talk about typos. Okay. So first of all, melatonin, you know, I'm a bit wary about it because it is actually a hormone, and it sort of we start secreting it, and by 3 months we've sort of done the most, and it's downhill from then on, and it does regulate our body's, you know, rhythm, and basically there is some interactions with it. So I was not wildly sort of impressed about this, and I was thinking, we don't know much about autism spectrum disorder and ADHD and all the problems that it causes, so why would you start throwing something like this at it? You know, yet another sort of one. And yet, surprisingly, when we had a look at this, and having a look at the dose, now the dose initially starts off, this is, I'm putting this in because often you'll have shared care with people with, you know, some of the children with autism spectrum disorder. The dose is actually a bit higher. It's an off-label use, more than what we've been giving people for primary insomnia. And so, you know, 2 to 3 milligrams. The person that I'd been asked about was actually on 12. And the idea is to give it 30 minutes before bedtime. Now, I was looking at some of the results here. This is averages, so it may not look fantastic, but we're looking at having a faster onset of sleep, having a longer duration of total sleep time, and a better quality. And this sort of may not look much, but it was enough in the case that we've got that it was particularly helpful for the young child, and it had been for a number of years. So obviously the doctors sort of got onto this a bit sooner. So it does improve the sleep duration, and it does mean that they'll get to sleep a lot faster, and that's an average. So I was thinking that that was actually quite effective. And then the same for ADHD. I definitely have a definite typo there. Again, sort of looking at the dosage used. It's higher, and still you can imagine it's not funded, so we do have to pay for it. That's one of the problems there. Again, quite effective. One of the things, the question I was asked was, what do we do with this child now that he was quite a large 13-year-old? Do we continue using the melatonin, or do we change the dose, or is it time to stop it? And that's one thing where I did not actually get the answer, so I'm still working on that. But I thought it was quite a positive aspect in a situation that's usually quite stressful for families as well, and that you get confronted with. And so melatonin is probably quite a good option. And I just have to summarise it also because really looking at it for primary insomnia in healthy adults, which is where I was sort of a little bit sceptical, you know, there's a very small inconsistent effect size. You wouldn't tend to be using it on a more long-term aspect on that, and sort of sleep latency, that the amounts are a lot smaller than if you're using it in spectrum disorder. People said, what about using it instead of benzodiazepines? If they're already on the benzodiazepine, it's not going to be effective for withdrawing them off the benzo. Probably the sort of agent to use before you use benzodiazepines, sort of effective, not quite as effective as benzos. And you can see there we don't know enough about the REM behaviour disorder or using it in the shift workers. But one of the things, because if you have a look on the website for Goodfellow Unit, you've got a quiz, because Bruce you've done quite a bit of research into the whole sleep deprivation, I shouldn't call it that, sleep restriction. Sleep restriction. And that. So I think there's probably other ways of dealing with insomnia, a little bit more than using drugs. But new one for autism spectrum disorder.
Yeah, I always find melatonin interesting. I saw an 8-year-old child who was the granddaughter of a woman I used to work with, very high-functioning family, and she'd been put on melatonin, and she just slept beautifully on it, and was just crazy off it, just not sleeping all night. And the parents were wondering about the toxicity, and so I looked up the toxicity, and I think it's been used in pregnant. I mean, there isn't much on the long-term toxicity of giving it to kids. This is from the Drug and Therapeutic Bulletin in the UK, and it was in a gym a couple of weeks ago, and I got an email from somebody in Australia saying, how dare you suggest this. It does say use it under specialist guidance, and I think with these sort of kiddies, that's probably a reasonable thing to do. But I suspect there's melatonin responders and melatonin non-responders, and so in the randomised trials, they sort of disappear. Anyway, we're going to finish on a nice note. Head lice. Okay. The bane of people's existence when their kids are at primary school. My kids had it, and in the end we gave up. But so there are things like combing, which are obviously the least toxic way to deal with these. But the tools for practice people in Edmonton, and I tend to pass on a lot of their, they become gems because I know they're very evidence-based. They have this machine there that produces a tool for practice every month at least. It's amazing. And these are the guys who do the podcast as well, so it's pretty amazing. So they did this review on head lice, and they found actually dimethicone was more effective than permethrin or malathion. 5% or 10% is available here. NNT of 4 when added to those things. So the extra benefit you get from adding that to those other ones in terms of addition. So the advice here, and it's presumably less toxic. I don't know whether it's off-label or not. It actually doesn't say what it's actually a barrier cream in New Zealand. Yeah. And the formulary doesn't really say much else, so I don't know whether you're using a section. Are you using a section 29 here, or what are you doing? I don't know. Yeah. Okay, so I'm not sure.
I'm off
so you leave it on for 8 hours, you put it on to drive here, leave it for 8 hours, and consider using it a week later. I think if that doesn't work, then you might want to try permethrin, malathion, and more combing. And then when all else fails, if the parents are really doing a war dance, then cotrimoxazole twice daily for 10 days. And then you might just suggest they give up and offer some mindfulness to the parents, because with my kids, one of them, it just never went away until she got old enough and presumably not in contact with, intimate contact with other kids. And that's it. I think that's the end, isn't it? Okay, so any questions? So, sorry, we should have said take questions as we go.